Hello, everyone, and welcome to our Cottage Primary Care Meet the Doctor webinar featuring Dr. Jane Varner, who will discuss navigating menopause and how to optimize your health and well-being during this time of change. I'm Christina Cortez, the Public Relations Manager for Cottage Health. Before we get started, I'd like to review a few housekeeping notes to optimize your viewing experience. First, at the conclusion of our presentation, we will host a brief question and answer session. So please use the Q&A button to ask Dr. Varner a question. And second, the webinar is also being recorded and will be emailed to you. So it's now my pleasure to introduce Dr. Jane Varner, primary care physician at Cottage Primary Care Santa Barbara. Dr. Varner is board certified by the American Board of Family Medicine and received her Bachelor's of Science in Biology from UCLA and her medical degree from Eastern Virginia Medical School. She completed her residency training in family medicine, including a year as chief resident at Medical College of Pennsylvania, Hahnemann University in Philadelphia. Over the past 25 years, Dr. Varner has developed special expertise in women's health issues ranging from contraception to menopause. She treats patients ages 10 and older, and Dr. Varner currently serves as the medical director for primary care at Cottage Health. So now I invite you to please join me in welcoming her.
Thank you all so much for joining today to learn more about the very important subject of menopause. After 25 years of practice in the Bay Area, I recently joined Cottage Health as the medical director of primary care. I was absolutely amazed to learn that Cottage Hospital was founded in 1891 by a group of Santa Barbara women led by Mary Ashley, who were fueled by determination and love for their community. For the past 125 years, Cottage Health has carried forward the tradition of women caring for women here on the Central Coast. I think that original group of women would be absolutely amazed and delighted to know that we are all gathered here today, joined by Zoom. So why are we here today talking about menopause? Well, there are 170 million women in the US, and it's estimated that 6,000 of those women reach menopause every day. We know that women outlive their ovaries for a variety of reasons. Natural menopause occurs when the ovaries simply age. Surgical menopause occurs when the ovaries are removed. Pharmacologic menopause occurs when anti-estrogen medications are used, and premature ovarian insufficiency, also known as POI, occurs when the ovaries just stop working, and sometimes that happens and we never really understand why. For women who transition through a natural menopause or kind of outlive their ovaries through aging, 51 years is the average age of a woman's final menstrual period. 81 years is the average life expectancy of a woman. And 30 years is the average time spent postmenopausal, which, if you do the math, is nearly 40% of a woman's life. We know that loss of ovarian function has a comprehensive impact on a woman's physical and mental health. Let me clarify some key terms. Perimenopausal describes the 3 to 5 year span before menopause when your symptoms begin. And for some women, this is even longer. Postmenopausal describes the absence of a woman's period for 12 consecutive months. The learning objectives for today are what, why, and how. What are the most common symptoms of menopause? Why do these symptoms occur? And how can you optimize your health and well-being as you navigate menopause? I spend time on the why because I think it's really important and empowering when you understand what is happening in your own body. So, as my kids would say, I'm going to nerd out on you and spend a few minutes reviewing the female reproductive cycle. So we're going to go back to the classroom. So this is the brain. And the hypothalamus is a part of the brain that is involved in signaling and a lot of functions that we'll talk about later. But the hypothalamus signals the pituitary gland, which is a nearby part of the brain, to release follicle stimulating hormone, also known as FSH, and luteinizing hormone, also known as LH. So here's the hypothalamus, and here's the pituitary gland. You can see that they're neighbors. So in this diagram, we have the uterus and we have the ovaries. And keep in mind that the ovary is about the size of a pea, and you can think of it as a tiny carton of eggs. In the first 2 weeks of the menstrual cycle, FSH, which remember comes from the pituitary gland, stimulates an ovarian follicle. And you can think of the follicle as kind of like the egg shell to grow. And as it grows, it releases estrogen, which prepares the uterus for a potential pregnancy. And in the middle of the cycle, the LH surge, so remember, LH is also coming from the pituitary gland, stimulates that ovarian follicle eggshell to break open and release the egg, a process known as ovulation, which of course you've all heard of. So you've got your ovary right here, about the size of a pea, kind of a neighbor of the uterus. And you've got the egg here and the egg shell or follicle. And you can see over the course of the cycle, it's growing and growing and growing and growing. And as it's growing, it's releasing lots of estrogen, which is preparing the uterus for a potential pregnancy. And then all of a sudden, you get this big release, this big surge of luteinizing hormone or LH, and it causes the follicle to crack open and release the egg. And that is going to be your ovulation. And then the broken follicle or eggshell becomes a structure called the corpus luteum. And that corpus luteum releases high amounts of the hormone progesterone in the second 2 weeks of the cycle, which then stabilizes the lining of the uterus. So to summarize, in the first half of the cycle, you have that growing follicle or eggshell, and it's releasing lots of nice estrogen, which is stimulating the growth of the lining of the uterus. So you can see in this first 2 weeks, lots of nice estrogen. And then ovulation occurs with the influence of that luteinizing hormone. And then that follicle, that broken follicle, becomes the corpus luteum, which then cranks out progesterone in the second half of the cycle. And then as progesterone rises, your PMS symptoms begin. And we're familiar with those, right? Irritability, fatigue, food cravings, breast tenderness, all of those great things. And then if there's no pregnancy, then the progesterone levels abruptly fall and you shed the lining of your uterus in the form of your period. And I love this cartoon. It's one of my favorites. Instead of a period, women should just get a nice text message from Mother Nature saying, "You're not pregnant. Have a nice day," right? That would make things so much easier on us. So let's dive in. Let's learn about what happens during menopause and why. So in menopause, the ovarian follicles begin to tire out, a process called senescence or aging. And they are no longer as responsive to that FSH signal from the pituitary gland. Remember, the FSH is the follicle stimulating hormone. And as the ovaries start to get older, they get a little tired and they're like, no more FSH. Like, we are not doing this anymore. So, but the FSH signal gets louder and louder and louder and says, come on, ovary, one more time. And so what we see here is that the estrogen and progesterone levels gradually fall as women transition through menopause, and that FSH level continues to rise. So what are the common symptoms of menopause? Let's do an overview and then we'll go through one by one. So hot flashes, irregular periods, also known as abnormal uterine bleeding, abbreviated AUB, weight gain, mood changes. You might feel depressed, anxious, irritable, impatient. A lot of women come into my clinic saying, I just don't feel like myself anymore. I don't know who this person is. I'm not getting along with my family. I'm not getting along with my coworkers. Poor sleep, brain fog, right? You're all of a sudden like every surface in your house, your desk, your car is covered with sticky notes, right? That's the only way you can get through your day. Genitourinary symptoms, which include frequent urination, urine leakage, recurrent bladder infections, vaginal dryness, painful intercourse, and finally, loss of libido, also known as your sex drive. And there are other symptoms of menopause that are a little less common. This is not a completely comprehensive list, but these are really the most common symptoms. And that's what we're going to spend time on today. So, before we talk about hot flashes, I just want to tell you that when I was a resident, we had continuity clinic once a week where we would go in and we'd see patients in the office. And one of the first patients that I saw, I walked into the exam room and she was sitting there and she was sweating, she was fanning herself, and she said, "Doctor, you have to help me." And keep in mind, I'm, 25, 26 years old. I'm barely out of puberty myself, haven't been through pregnancy, nothing. And they don't teach you about anything about menopause in medical school. And I was just sort of standing there without a clue what to do. And I find it so funny that, fast forward almost 30 years, and here I am talking to all of you today about menopause. And I have my own fan. So maybe some of you brought yours today as well. So, with declining estrogen levels, the body's temperature regulation center in the brain becomes much more sensitive to even minor increases in body temperature. Again, we're talking about the hypothalamus, right? We saw the slide a few slides back. That hypothalamus is where your body temperature is regulated as well. And so that regulation center in the brain is much more sensitive. And even a tenth of a degree rise in your body temperature can trigger a hot flash. So ordinarily, we can tolerate up to half a degree rise in our body temperature before those cooling mechanisms kick in. But when we're going through menopause, it's much more sensitive. So even a tenth of a degree rise in our basal body temperature triggers those cooling mechanisms. And what are those cooling mechanisms? Well, we're familiar with those. Sudden and rapid blood vessel dilation, also known as flushing, and perspiration are your body's attempt to cool you off. I always say that we misnamed hot flashes, right? We feel hot, but in reality, it's our body's attempt to cool us. We should have called them cooling flashes. Hot flash triggers are really anything that raise your body temperature. So stress, right? You're getting ready to go in a meeting and, give a presentation. And of course, you're having hot flashes. Sleeping raises your basal body temperature. Warm liquids like a hot cup of coffee or tea can trigger a hot flash, even spicy food. Hot flashes are the most common symptom of menopause. 80% of women are affected by hot flashes, but studies tell us that only 20% of women actually seek treatment for their hot flashes. Hot flashes can range from 1 or 2 per day to 1 or 2 per hour, including overnight. It's not like there's a hot flash switch that you can just turn off when you go to bed. A lot of women are just laying awake all night, tossing and turning and sweating. Hot flashes typically last 4 or 5 years, but 30% of women have hot flashes lasting for as long as 10 years, and 10% of women have hot flashes for 20 years or more. So this is really a significant issue. Risk factors for kind of being more affected by hot flashes include obesity, smoking cigarettes, a sedentary lifestyle, your genetics, and even your ethnicity. Studies have shown us that African American women report more hot flashes that tend to last longer. So let's talk about irregular periods, also known as abnormal uterine bleeding. We learned that less frequent ovulation occurs as the ovaries age, and then less frequent ovulation can lead to irregular bleeding. Ovulation is that kind of critically important, it's the timekeeper of the reproductive cycle. It keeps things nice and regular, kind of keeps you having that monthly cycle. And so when you're not ovulating, that timekeeper kind of goes away and it's fair game, right? So sometimes your cycles might be a little bit shorter and your periods are closer together. And sometimes your cycle might be a little bit longer, your periods are farther apart. The amount and duration of your bleeding can be really variable. And sometimes, it might just be like a little bit of light spotting, and then you're feeling optimistic, like, oh, I think I'm done. I might be, done with menopause. And then all of a sudden, a month or two later, you have just a whopper of a period where you're soaking through tampons and pads. And that's actually a really common pattern. And I always say that the only thing predictable about your period during the menopausal transition is that it will be unpredictable. About weight gain. So women gain an average of 10 pounds over 5 years during the menopausal transition, but this can actually range from 5 to 20 pounds or even more. Declining estrogen levels lead to the conversion of muscle mass to fatty tissue, a process known as sarcopenia. Sarco refers to muscle and penia refers to loss. So, this is something that is happening beyond your control. I mean, a lot of us know that we could be exercising more regularly, right? Sometimes we're really good about getting to the gym, sometimes we're not. But this is all happening. This is not within your control. When your ovaries stop producing estrogen, you are losing lean muscle mass, period. Lower muscle mass leads to lower resting metabolism and weight gain because muscle tissue burns more calories than fat. And so as you lose your muscle tissue, your metabolism drops. And we know as you're going through menopause, fat tends to concentrate in the midsection, also known as visceral fat, which is a risk factor for cardiovascular disease. So, up until we go through menopause, we might carry extra weight in our butt and our hips. But then when we go through menopause, then we get that what we all know as lovingly as the muffin top, right? Um, the other thing is that estrogen also promotes the feeling of satiety or fullness in the brain. So, again, the hypothalamus is your satiety center. And so, when your estrogen levels fall, then that satiety signaling kind of goes haywire. And so, even though you may have eaten the right amount of food, you still might feel hungry and be driven to eat more. So, really, there's a couple forces at play here in terms of menopausal weight gain. One is the change in your body composition, and the other is kind of that satiety signal going a little bit haywire. Let's talk about mood changes. Many women report new or worsening feelings of depression, anxiety, irritability, impatience. This is super common. There is a reason for this. It's not just you. Serotonin, which you may have heard of, is the brain chemical that mediates feelings of happiness and calm and well-being. It's very, very important. And it turns out that estrogen promotes the formation of serotonin in the brain and allows the brain to use it more efficiently. So estrogen actually impacts serotonin in two ways: promotes the formation of serotonin and allows the brain to use it more efficiently. That's really, really important because as estrogen levels fall as we transition through menopause, so does serotonin activity. And this has a powerful impact on mood. Low serotonin is an important contributor, but mood changes during the menopausal transition most likely represent the interplay of many forces that are occurring midlife in women. Our physiological changes that we are reviewing here today: hot flashes, weight gain, poor sleep, but also significant life events. Launching of young adult children. Some are going off to college. Some of us are facing empty nest. That's hard. Caring for aging parents, right? All of a sudden, you get a call from the emergency room, and mom's fallen and broken her hip, or dad's losing his memory, and And that can be really, really stressful. Financial stress, secondary to the above, right? Well, we're trying to figure out how we're going to pay for college. We're also trying to figure out how we're going to cover home care for our aging parents. And also relationship stress. All these things going on in life can be tough. Going on in life can be tough on the marriage. So it's really the mood changes have a lot to do with estrogen and serotonin. But they also have a lot to do with everything that's happening in midlife. It's a very hard time. So let's talk about sleep. Your circadian rhythm, which you all may have heard of, really kind of broadly describes your light dark cycle. When it's dark outside, the brain's pineal gland, kind of a cousin of the pituitary gland, another gland, synthesizes and releases melatonin. When it's light, the synthesis and release of melatonin shuts down, which is a really good thing because melatonin makes you very sleepy. So when it's dark, you're making melatonin, and when it's light, you're shutting down the production of melatonin. During menopause, melatonin production falls. Serotonin, as it turns out, is the precursor molecule to melatonin. And since serotonin production is falling with declining estrogen levels, so is melatonin, which kind of throws off your natural circadian rhythm or light dark cycle, which can be very disruptive to your sleep. But as with mood changes, poor sleep is also likely multifactorial. Anxiety can lead to difficulty falling asleep. We spend time tossing and turning at night, worrying about this and that, kids, work, everything. Hot flashes can lead to multiple nighttime awakenings, interrupting your REM sleep. Remember, your REM sleep is that stage of sleep that makes you feel refreshed and restored and be able to remember things. And when you're having hot flashes all night long, you're not getting sufficient REM sleep, and you can feel really groggy during the day. Waking associated with menopause can lead to a lot of snoring, which can be disruptive to sleep, and even new onset sleep apnea. So let's talk about brain fog. So remember, I referred to all the sticky notes, right? Well, it turns out a landmark study done at Cornell University, the Cornell Women's Brain Initiative, looked at the structure and activity of 160 women's brains between the ages of 40 and 60. That's a lot of brains to look at, right? The significant findings were decreased glucose utilization in the temporal lobes. So the temporal lobes are involved in memory, and glucose is really glucose utilization is an indicator of metabolism. So basically, there was less activity in the memory centers of the brain. Decreased gray matter volume in the inferior temporal gyrus. You don't have to remember that. That's a lot of big words there. But basically, that's another section of the brain that's involved in memory, language comprehension, and visual perception. An overall decrease in white matter volume, and white matter is involved in speed of processing in the brain. So loss of metabolism, loss of volume, loss of white matter volume in the brain translates to brain fog. So this is real. But the good news that came out of this study as well showed that as women traveled through menopause, that a lot of these changes were reversed, and a lot of women regained the cognitive function that they felt that they had lost during the menopausal transition. So that's a bit of good news. This is one of my favorite cartoons. I love this. If I had $1 for every time I got distracted, wish I had some ice cream, right? This is unfortunately how many menopausal women spend a good part of their day. Let's talk about the genitourinary symptoms. Vaginal dryness. The vaginal lining tends to thin out and becomes very dry and much more delicate. And this can lead to significant discomfort during intercourse or even just during the day and during your regular activities. It's uncomfortable to sit on the spin bike, right? Overactive bladder. Declining estrogen leads to an increased number of stretch receptors in the bladder wall. So that's how you know you have to pee, right? Your bladder is lined with all these stretch receptors, and when your bladder fills up, those stretch receptors signal the brain, okay, it's time to pee, and then you go to the bathroom and you pee. And so in the absence of estrogen, those stretch receptors actually upregulate, so it sends a much louder signal to the brain, even with just a little bit of volume in the bladder. So that leads to that sense of urgency and that frequency, like you feel like you're always having to run to the bathroom, and you're like, well, I didn't even have to pee that badly. What's up with that? And it just has to do with the fact that that signal is getting a lot louder. Leakage, also known as stress urinary incontinence. Low estrogen contributes to pelvic floor muscle weakening and loss of support around the opening to the bladder, which is also known as the urethra. And then increased frequency of bladder infections happens because estrogen withdrawal leads to a change in the vaginal pH. And that the pH refers to the sort of acidity of the vagina and increases the susceptibility to overgrowth of bacteria, and that which can then ascend into the bladder and cause bladder infections. So all of these, we call this the genitourinary syndrome of menopause. These are all very real and common symptoms of menopause. And then finally, we'll talk about low libido or sex drive. Again, this is another one of those things that's multifactorial, right? The insomnia that we see with menopause causes a lot of fatigue, and you're not really, feeling up for having sex, right? Mood changes such as depression and anxiety, relationship issues. Weight can lead to poor self-esteem. You don't really, you don't feel good about your body. Vaginal dryness and worried about the discomfort during intercourse, and then even urinary incontinence and worried about leakage during sex, right? All of these things happen during menopause and contribute to kind of like your loss of your sex drive. And I would be remiss if I didn't mention some really important related health conditions. One is loss of bone density. We talked about sarcopenia being the loss of muscle mass. Osteopenia refers to the loss of bone density. And when you have enough loss of your bone density that you become at significantly higher risk for having a fracture, that condition is called osteoporosis. And what happens is estrogen converts vitamin D to its active form, which is needed to absorb calcium from the gastrointestinal tract. And without sufficient calcium, bone loss occurs. Prediabetes and type 2 diabetes. Weight gain that we see with menopause leads to insulin resistance. Insulin is the hormone that actually helps you to move blood sugar that you have absorbed through your digestion into your cells. And so with weight gain, we see insulin not working as well, prediabetes, and even type 2 diabetes. High cholesterol. Menopause typically leads to somewhere between a 5 and 10% rise in LDL cholesterol. And LDL cholesterol, also known as low density lipoprotein or bad cholesterol, is the building block of plaques that form in the coronary arteries. And even if you don't really change anything about your activity level or your diet, then your LDL tends to rise a bit. High blood pressure. So when you gain weight, you typically you're at risk for having a little bit of bump in your blood pressure as well. So these are all things that we need to look out for as we transition through menopause. So let's transition to optimizing your health and well-being. We've talked about a lot of stuff that's rough, right? And so what are some things that you and your clinician, your healthcare provider can do to help you navigate this more gracefully? So if we were living in Victorian England, these would be our options. An ovariotomy, which was done, which is where a procedure where they actually removed a woman's ovaries without any anesthesia. And no surprise, it had a 100% mortality rate, meaning that every single woman that they did this to died. So not a great option. Or you could eat ground mammalian ovaries, right? The most primitive form of hormone replacement. Or you could just get committed to basically an insane asylum that they called a hysterium, which was an asylum designated for menopausal women. Thankfully, we have better options. Let's talk about hormone replacement therapy. So, what exactly is hormone replacement therapy? We hear a lot about it in the news. And so, what is it? So, hormone replacement therapy is really it's close replications of naturally produced female hormones, estrogen and progesterone. We've been talking about these through the talk, right? They are also sometimes referred to as bioidenticals because they are biologically identical to what we make in our bodies. Estrogen and progesterone are prescribed in women who still have a uterus. This is really, really important because we learned earlier in the talk that the effect that estrogen has on the lining of the uterus is it stimulates it, right? It develops it, it prepares it for a potential pregnancy. And if you just have day after day, month after month, year after year, unopposed stimulation of the lining of the uterus, then you might develop a cancer, right? And we don't want that. So, what we do to mitigate that risk of cancer of the lining of the uterus is we also prescribe a progesterone, and the progesterone atrophies that lining. So, if you have a uterus and you want to start taking hormone replacement therapy, you need estrogen and progesterone. If you do not have a uterus any longer, if you had a hysterectomy because you had, gigantic fibroids or something like that, then you don't need the progesterone. You can just take estrogen. It's also important to note that hormone replacement therapy, although it is estrogen and progesterone, it is not the same thing as contraception, right? Hormone replacement therapy is not birth control. It's different from birth control because the estrogen and progesterone are in hormone replacement are in lower doses. Hormone replacement is not designed to suppress your ovulation. The hormone levels, the estrogen and progesterone in birth control pills are in high enough doses to suppress ovulation, and that is how they prevent pregnancy. But that's kind of not the point of hormone replacement therapy. So they're different things, even though they both contain estrogen and progesterone. So estrogen comes in many forms. It comes in tablets, it comes in patches, it comes in a ring. Progesterone also comes in many forms, also a tablet, also a patch. You can get a patch that's got the estrogen and progesterone together. It also comes in the form of an IUD. The Mirena IUD is very popular. It releases progesterone directly into the uterus. How does hormone replacement therapy help? Well, let's go through it. Hormone replacement therapy is FDA approved for relief of hot flashes, relief of genitourinary symptoms, and preservation of bone density or prevention of osteoporosis. That is what hormone replacement therapy has FDA approval for. But hormone replacement therapy may also help with sleep, mood, and overall sense of well-being. I prescribe hormone replacement therapy all the time, and my patients come back and say, I feel so much better, right? Or I don't feel better yet. And then we give them a kind of turn up the dose a little bit. But hormone replacement therapy usually helps with all of these other symptoms as well. It has not been definitively shown to help with cognition or brain fog, but again, a lot of women feel like, when their sleep is improved and their mood is improved, their cognition is improved. So it's all kind of related. Hormone replacement therapy may lead to a little bit of loss of that belly fat that we gain in menopause, but not that fat in the butt and hips that we went into menopause with already. Is hormone replacement therapy safe? Well, that's a really important question. And in the early 2000s, we had the Women's Health Initiative, which was the largest study ever done on hormone replacement therapy. And hormone replacement therapy got a pretty bad rap after the results of that study were published. And we spent about 2 decades taking women off of hormone replacement therapy. And then we went back and we took another look at the data and realized that maybe we could have interpreted the data a little bit better. And now we've kind of reversed course on hormone replacement therapy. and find that it is safe and effective for women in their late 40s, 50s. The current recommendation is to think about discontinuing it around 60, early 60s, or 10 years after the final menstrual period. The current position statement of the North American Menopause Society on hormone replacement therapy is that for women aged younger than 60 years or within 10 years of menopause onset and without contraindications, and we'll talk about those, the benefit risk ratio appears favorable. So this is the position statement of the North American Menopause Society. And in fact, new analysis, ongoing analysis of the Women's Health Initiative data show that hormone replacement therapy may actually be more beneficial to our cardiovascular health more than previously thought. And there's going to be more to come on that. We generally consider the patch form of estrogen the safest. Data show us that transdermal estrogen or patch form of estrogen is linked to the lowest risk of venous thromboembolism, also known as blood clot. The contraindications to hormone replacement therapy: you should not take hormone replacement therapy if you smoke cigarettes. There's too high of a risk of clot. If you have a history of breast cancer or a very high risk of breast cancer, if you have a prior history of blood clots, and I always say use with caution if you have a history of high blood pressure. We know that estrogen can bump up your blood pressure a little bit, and estrogen can also trigger migraines. So use with caution if you have a history of high blood pressure and or migraines. Let's move on and talk about intravaginal estrogen. So this also comes in many forms. It comes in a cream, comes again in an intravaginal ring, and it comes in vaginal inserts like little capsules that you can insert. We generally recommend using intravaginal estrogen if the genitourinary symptoms are your main issue. And remember, those genitourinary symptoms are the dryness, the irritation, the frequent UTIs, leakage. If that's really the main symptom, you're not having really too much trouble with the hot flashes, everything's pretty okay, but the genitourinary symptoms are really getting to you, then intravaginal estrogen is a great solution. We typically start with once daily for 14 days and then decrease to twice weekly thereafter. And if you're only using it a couple of times a week, or you have that really, really low dose estrogen ring, then you do not need to add a progesterone because you're not getting too much stimulation in the lining of your uterus. Let's talk about birth control pills. So oral contraceptives or birth control pills can be used through the early 50s for contraception, cycle regulation, help with hot flashes. Good options are low-dose pills. I like Yaz, Merced, low estrogen. Women still need contraception until their periods are done. There is a 2 to 3% chance of pregnancy in women 45 to 49 years. I have women who come into the office all the time and they're like, I don't need birth control anymore. I'm like 48. What are the chances of me getting pregnant? Well, you can. If you're still getting a fairly regular cycle, then odds are that you are still ovulating. And if you're still ovulating, you still can get pregnant. Birth control pills will suppress FSH release because remember, we talked about how birth control pills are combinations of estrogen and progesterone. And when in higher levels, they'll actually give a negative feedback signal up to that pituitary gland and they'll suppress the FSH release. So you can't, while you're taking birth control pills, you can't really reliably measure the FSH level to determine if you're in menopause. So you kind of have to, determine if you're postmenopausal. You have to stop the birth control pills, wait a cycle, and then measure the FSH. And we generally consider an FSH level of greater than 25. That means that you are postmenopausal. At that point, you can have a conversation about transitioning over to hormone replacement therapy from your birth control pill. Let's talk about SSRIs, also known as selective serotonin reuptake inhibitors. So SSRIs can help with hot flashes and mood. We see, although SSRIs can take several weeks to improve mood, they can improve hot flashes within a few days. Common side effects of SSRIs include dry mouth, diarrhea, nausea, headache, and decreased libido. And so it turns out if you start low and kind of gradually increase the dose, then a lot of times you don't really experience these side effects of the SSRI. So that's generally my approach. And if you stay on an SSRI for long enough, then some of these side effects actually typically will get a lot better. Studies have shown that Paxil is the SSRI that's most effective for mitigating hot flashes. Unfortunately, weight gain is an almost universal side effect with Paxil. And so I think most practitioners have really moved away from prescribing Paxil, especially in menopausal women. You will not make any friends by giving them something that's going to gain even more weight. Celexa and Lexapro and Effexor are really the preferred SSRIs due to their efficacy, tolerability. You can also use them with tamoxifen. So if you have a woman who is, going through breast cancer treatment with tamoxifen and having a lot of hot flashes, these SSRIs are going to be a really good choice. Zoloft and Prozac in studies have not been shown to be as effective for hot flashes. So really, Celexa, Lexapro, and Effexor, if you're having a lot of hot flashes, you can talk to your provider about maybe starting one of these. If you are not a candidate for hormone replacement therapy and you tried an SSRI and didn't like it so much, gabapentin and pregabalin, these are cousins, studies have shown that they are pretty effective in helping with hot flashes, although this is off-label use. Gabapentin can cause sedation, so I typically start with a pretty low dose and then kind of titrate it up. You can also just try a bedtime dose if, really what you're trying to help is that overnight hot flashes. Just a bedtime dose of gabapentin can help with sleep and with the hot flashes. It's also useful for chronic pain and mood stabilization. Pregabalin, also called Lyrica, a cousin of gabapentin, similarly 75 milligrams twice a day, can also be helpful for mitigating hot flashes and might be a really nice choice if you're also dealing with chronic pain. This is a new class of medications, the neurokinin B receptor blockers. That's a mouthful. You absolutely do not have to remember that. But the NKB receptor blockers are a new class of medication. They were FDA approved in May of 2023. They work on the temperature regulation center in the brain, going back to the hypothalamus once more, preventing that vasodilation and perspiration that we see with hot flashes. They're a great choice for women who, like I said, can't take HRT, can't tolerate SSRIs. They are safe. They are FDA approved. There is a recommendation to monitor liver function quarterly when taking fezolinetant or Veoza. This is the commercially available NKB receptor blocker. You've probably seen lots of commercials for Veoza. I even saw one during the Super Bowl, which was pretty funny to me. Exercise, right? Helps with mood, sleep, weight gain, bone density, and cardiovascular health. It's great. Everybody should be exercising. Alone, it hasn't been shown to be too much help for hot flashes. I recommend targeting a minimum of 150 minutes of moderate intensity exercise per week. This is for everybody. Regardless of your age, regardless of your gender, everybody should be targeting exercise. Strength training is really, really, really important to mitigate the natural loss of muscle mass. You can combine it with cardio exercise. I love boot camp style exercise because you're moving, you're getting that cardio workout, but you're also getting the strength training. We talked about that sarcopenia, right? That loss of lean muscle mass. Strength training is a great solution. Herbal therapies. In some randomized controlled trials, black cohosh and plant-based estrogens, also called phytoestrogens, modestly reduced hot flashes, but less than placebo. There is a general recommendation to use black cohosh for a maximum of 6 months. I'm not really sure why this is, but if you read about black cohosh, almost everything that you read says safe for 6 months, safe for 6 months. So I generally recommend just use black cohosh for 6 months, but it can be helpful. A word about compounded hormones. Many women out there are using compounded hormones. These are custom-made hormones that are prescribed by a clinician and compounded in a pharmacy or made in a pharmacy for an individual patient. They can be made in a variety of forms, including tablets, creams, injectables, suppositories. Keep in mind, compounded hormones are not regulated by the FDA. They are not subject to the same safety, efficacy, or dosing consistency tests as regulated hormone replacement therapy. They may contain additives, preservatives, or other drugs that are made in the same pharmacy. They may have inconsistent doses and purity. So I'm not going to say don't ever use compounded because I won't make any friends that way, but just use them with caution because they're not subject to the same scrutiny and rigor that FDA regulated HRT is subject to. Yoga and meditation. One study showed that regular yoga practice 3 times a week reduced hot flashes by 30%. That's pretty significant. You can alternate yoga with weightlifting and cardio exercise. Meditation also helps. One study showed that a 40% reduction in hot flashes with once weekly 30-minute meditation sessions continued for 8 weeks. If you don't really know how to meditate, apps like Headspace and Calm can be really helpful. Menopause is a growing industry, so I want you all to be smart consumers. Right now, it's estimated that menopause is about a $5 billion industry, and it's projected to grow to about a $10 billion industry over the next 10 years. So what makes up that industry, right, why do we think of menopause as an industry? Well, there are tons and tons of supplements out there that are promising everything from relief of the brain fog that we talked about, the weight gain that we talked about, the loss of libido that we talked about. I don't think any of these are going to hurt you. I can't promise they're going to help. There are a lot out there. Femtech, right? Female-centered technologies. There are all kinds of things that are also promising to help with the symptoms of menopause. We've got, contraptions that you can sleep in, things that you can tuck into your mattress to keep you cool at night, wearables like, wrist devices that you can press if you're having a hot flash and it's supposed to mitigate the hot flash, portable neck fans. It's a whole industry. So again, none of this is going to hurt you, but I want you to be smart consumers. The rise of digital menopause care is important, right? We know that we talked about in the beginning that there are 6,000 women in America that are aging into menopause every day. There are not enough providers locally to help you navigate menopause. So Janab, Ovia, Stella, MIDI, these are all services that you can access online that will help you with your menopausal transition. I'm not endorsing any of them in particular, but I'm just calling out that they are available to you. I will say that if you are a woman who is experiencing really irregular bleeding, monstrously heavy periods, like go in and get seen, right? See your family doctor, see your OBGYN, get an exam. You might need an ultrasound. Don't over rely on digital management of your menopause. There are lots of apps out there that will help you track symptoms and link to content. And again, I don't endorse any of these in particular, but I think they're really useful, particularly if you're going to start an intervention. Say you start hormone replacement therapy or an SSRI or black cohosh or an exercise program or all of the above, then you're going to want to track your symptoms because that will help you and your care provider decide if that is actually helping you. So again, I don't endorse any one of these in particular, but I do think it's useful to track your symptoms. We even have a musical now, right? And then we all love the Barbie movie, and I'm hoping that they're going to make a sequel, right? Barbie turns 50 and make a movie about Barbie's journey through menopause. That would be great, right? Menopause is in the news, and in March of this year, so exciting, with the encouragement of our First Lady, Jill Biden, President Biden signed an executive order directing $12 billion to support women's health research more broadly. And in May of this year, Senate Bill 4246 was introduced by Senators Murray, Murkowski, Baldwin, Collins, and Klobuchar. Bipartisan legislation calling for $275 million in funding specifically for menopause research, training, and awareness. This is super important. After introduction, the bill was moved to the Senate Health, Labor, Education, and Pensions Committee for further review and discussion, so it is still on the table. Write your senators, right? Senate Bill 4246, you heard it here. This is really, really important. Good reads. There's lots of information out there about menopause. There are lots of books and podcasts and information on the web. These are some of my favorites. Menopause Manifesto is a great one. If you have to pick one to start with, this is really, truly one of my favorites. Menopause Guidebook published by North American Menopause Society, also a wonderful resource. And then you can also go directly to the North American Menopause Society, now known as the Menopause Society, at menopause.org. And I'll leave you with my parting thoughts. As women, our health is on display, right? From the time we start puberty and have to go into the store and buy our first box of tampons. We fight unconscious bias from the time we hit puberty, and menopause is no exception. Hot flashes, weight gain, mood swings, sleeplessness, brain fog, abnormal bleeding. These are really, really, really hard to navigate. I can't emphasize that enough. And yet, too often, women are suffering in silence. Menopause has been stigmatized for too long, and the antidote is dialogue. We need to talk about it, just like we're doing here today, right? Talk about what you're experiencing. Talk about it with your neighbors. Talk about it with your friends. Talk about it with your care provider. Talk about it, cry about it, even laugh about it, right? Women, the Central Coast, California, and beyond, if we gain some momentum here today, let's keep it going. Thank you so much for showing up today. I really, really appreciate it.
Thank you, Dr. Varner, for that wonderful presentation. I learned so much, and I'm sure our attendees did too. We'd now like to open the room to questions. As a reminder, to submit your questions, please drop them in the Q&A box, and I'll read them out loud to Dr. Varner. So we'll get started with our first question here. When should one start having mammograms, and how often?
That's a great question, and I'm glad somebody asked that. Breast cancer screening is really, really important, and it can be a little bit confusing for both patients and for care providers. If you look at the U.S. Preventative Services Task Force recommendations, they say beginning at the age of 50 and every 2 years is the recommended schedule for mammogram screening. But then if you jump over to the American College of Radiology, so a radiologist is somebody who reads mammograms, and the American College of Radiology is kind of the academic governing society for radiology. If you look at the ACR guidelines, they say start mammography in the early 40s, and women should be having mammograms every year beginning at the age of 40. It's estimated that about 40% of new breast cancer diagnoses are in women in their 40s. And so I think that really informs those guidelines. And so I tend to default to the ACR guidelines. They're a little bit more conservative. I think American College of OB/GYN generally endorses those guidelines as well. And so when I see patients, I generally recommend starting mammograms beginning at 40 and continuing every year.
Great, thank you so much. That's really helpful. We have a few HRT related questions. So our first one is, if your HRT has reduced the frequency of hot flashes, but not other symptoms, would switching to a different type or brand be beneficial?
So that's a great question. It kind of depends on what the other symptoms are. And I actually love combining HRT with SSRIs. I think that you get a really, really nice synergy. And remember that the SSRIs are the medications that we talked about that boost serotonin. I also call them the serotonin boosters because of serotonin levels have fallen. And so those are medicines like Lexapro and Celexa and Effexor. And what I like is because you can get kind of a synergy, meaning that like, combining them gives you a greater effect than having just one on its own. You can kind of have lower doses of your HRT and stick with kind of a lower dose of your estrogen progesterone, and then you can also have like a lower dose of your SSRI, and that combination can be really effective for sort of globally improving your menopause symptoms. So a couple options. If you're not getting the desired effect, you can turn up the dosing on your HRT. You could potentially switch to a different kind, or you could add in another medication like an SSRI.
Great, thank you so much. So another HRT related question, and I'll try to tie it into the following one, which is also HRT related. If someone is experiencing minimal symptoms of menopause, is HRT recommended for its cardiovascular health benefits?
Yeah, that's a great question, and I think so. Right now, the way it stands, we don't use HRT to prevent cardiovascular disease. That may change in coming years as we continue to look at the data that we got from the Women's Health Initiative. And in fact, we're already starting to learn that HRT might be more beneficial for cardiovascular health than we thought. However, on the other side of that, you have to be careful. What are the risk factors for cardiovascular health? High blood pressure, high cholesterol, and so we know you have to be careful about using HRT in women who are already hypertensive, because that estrogen can bump up the blood pressure. So again, it's really important because this is kind of the benefits of HRT on cardiovascular health is a little bit nuanced, and there's a lot that we're still learning. Then this is really a great opportunity for shared decision making with your menopause care provider.
Thank you. We have a couple of questions related to, and if you could speak to a little bit of addressing joint pain post-menopause, and if the symptoms can be improved with hormones, drugs, or supplements.
Yeah, that's a really good question, and I didn't have time to kind of go through like the entire list of symptoms that women might experience in menopause, and joint pain is definitely on the list. It's hard to comment on that though, because there's so many different causes of joint pain. And so, the doctor in me says, if you're experiencing new onset joint pain, don't necessarily just chalk it up to menopause. It might be menopause, but very often in midlife, we're seeing like the onset of new rheumatologic conditions like rheumatoid arthritis, fibromyalgia, things like that. And so if you're experiencing new onset joint pain, then I think that you should talk to your care provider about that and have a little bit of an evaluation, make sure that you're treating the right thing. It's possible that if you have a workup and it's negative, and you maybe starting to experience some of the other symptoms of menopause, starting a little HRT might be helpful. If really chronic pain is something that you are dealing with, then maybe something like we talked a little bit about Neurontin, we talked a little bit about Lyrica. That might be a better choice for you.
Great, thank you. One question that I'm sure everyone is wondering about is it still possible to lose weight during menopause?
Yes. So it is. It's harder. I'm not going to deny that because your resting metabolism goes down, but it is possible to lose weight. And I really can't emphasize enough the importance of the strength training and combining that with your cardio exercise. It's interesting. A lot of women ask me about the class of medications called GLP-1 agonists, and those are going to be medications like Wegovy and Ozempic, Zepbound, all of those that you're hearing about in the news, and everybody seems to be on trying to lose weight. And they're actually starting to do some studies looking at dosing, looking at low dose GLP-1 agonists in menopausal women as to help with the weight gain. The downside of that, couple downsides. One is that the GLP-1 agonists are known to accelerate loss of muscle mass. So you're kind of already naturally experiencing that in menopause, and so you want to be careful about adding something that might make that problem worse in the long term. And then there have been sort of like there's mixed reviews on the impact on mood, and there's some studies that show that the GLP-1 agonists are helpful to mood, and they can help with feelings of anxiety and depression. And then there are some studies that have been done, some in Europe, that have shown that they actually have a negative impact on mood. And so, those are just some things that you need to consider. So, but yes, it is possible to lose weight in menopause, but you just have to be, really disciplined about your exercise, especially your strength training, rebuilding some of that muscle, and be patient because it takes a little while to rebuild muscle as well. So you just have to be, consistent and give it a little bit of time.
Great, thank you so much. How long does brain fog typically last?
Yeah, so that's a great question, and I think there's that the Cornell study wasn't really specific. I mean, that was probably the most important study that's been done in menopausal brain fog, and so probably as you kind of move into your late 50s, kind of early 60s, is when that menopausal brain fog tends to lift a little bit.
Okay.
But even though there aren't studies that there isn't really specific data that shows that hormone replacement therapy mitigates the brain fog. Like there's not an actual study that proves that. A lot of women will tell you that they feel a lot better, and also sleep plays such an important role in that. And then if your sleep improves, right then and there, your brain fog might lift a little bit.
Great, thank you. Two different questions regarding screening. One is, how often are you supposed to have a PAP after the age of 60? And the other one is, at what age do you stop getting mammograms? Or do you ever stop?
Yeah, and so those are both great questions, and again, I sort of characterize those as an opportunity for shared decision making. The current sort of formal recommendation is that you stop cervical cancer screening at the age of 65, and then you stop breast cancer screening somewhere between 65 and 70. But I think that I'm just going to give you sort of a scenario where I might go a little bit longer for cervical cancer screening. So if I have a woman who has had an abnormal pap smear and I want to make, absolute certain that she has, doesn't have any residual abnormal cervical cells, then I might actually continue cervical cancer screenings for a little bit longer just to make sure that I have a few normal, right? I'm not going to have a slightly abnormal one and then, repeat it at a year and say she's right, at 64 and then 65, and then she's got a normal one, and then say, okay, we're done. I'm probably going to get like 2 or 3 in a row to make sure that they're all normal before I say, look, you can be done with cervical cancer screening. Similarly with breast cancer screening, I typically go longer. Women live longer. Women live to 81. If I have a patient who is in really poor health, right, doesn't have a long life expectancy, certainly wouldn't be able to tolerate treatment for breast cancer, then I'm not going to go looking for a breast cancer. But if I've got a woman who's 72 in great health, not a lot of medical problems, then I'm going to continue with breast cancer screening.
Great, thank you so much. Geez, time is flying by. We have time for one more question. We received so many questions, such great questions. Our last question is, what guidance do you have for women in their early 40s in terms of things they can do to maximize their health in a way that may ease the transition to menopause?
Yeah, I love that question, actually. I think that's so important. And I hope that there are some women who joined today who are in their early 40s, right? Because this is a preview. And I love ending on this note. So it's really important that you maximize your bone density now, right? You still have estrogen, you're still making that active form of vitamin D, you're still getting calcium absorption, and you can still make bone. And so To really optimize your bone health, you want to be getting at least 1,200 milligrams of calcium. You want to be getting at least 1,000 international units. If you're a little low, 2,000 international units of vitamin D every day. You want to be getting regular weight-bearing forms of exercise. This includes like common cardio forms of exercise like walking or jogging, but also strength training. That's great for optimizing your bone health as well. Um, just to review, great dietary sources of calcium are going to be anything dairy, anything soy, legumes, dark green leafy veggies like kale and spinach, and then cold water fishes like salmon and sardines are really good dietary sources of calcium. If you don't really eat many of those foods, then take a calcium. I really like the chewable calciums like Bioactive. Comes with vitamin D built into it. You get the generic of it. But calcium D, regular weight-bearing forms of exercise to optimize your bone health, start getting your mammograms, kind of just get in that habit, keep up with your cervical cancer screenings. That's going to be the current guidelines are every 5 years if you're getting an HPV screen and a PAP at the same time. If everything's normal, then every 5 years. And I think, getting really kind of circling back to exercise, not only in the context of bone health, but also in the context of really building up your muscle stores so that you go into menopause with some like nice solid muscle mass and also a good routine. A lot of people think, okay, well, if I'm not getting to like a hit workout at the gym for an hour every day, then I'm not really exercising. But really, any amount of physical activity that you're doing is exercise. I love Tabata workouts, right? Tabata is the Japanese workout where you do, a few repetitions of super high intensity exercise, and that just really revs up your metabolism. So, when you're in your 40s and you're raising kids and you're working and you're trying to, have a relationship and there's all this that's going on in your life. Sometimes you need to get creative about your exercise and figure out how to do it. Get some equipment to have at home. Do some. There's a lot of great exercise videos on the web that you can look at if you don't really know how to strength train. But develop really good exercise habits. Start building up that muscle mass. Preserve your bone density. Stay in the habit of your cancer screenings, your breast cancer screenings beginning at 40, keeping up with your cervical cancer screenings. And remember that now we start colon cancer screening beginning at the age of 45, and that's pretty new. In the last year or two, the American College of Gastroenterology changed the recommendation from starting at 50 to starting at 45. So if you don't know that yet, then make sure that you're getting in there to also start your colon cancer screenings beginning at 45, even earlier if you have first degree family member with colon cancer. So I think that was kind of a big download. So I'm trying to get in as much as I can in my remaining minutes. I know we've gone a little bit over. I don't know if there are any other pressing questions or if you want to wrap.
Well, I think that's all the time we have now. But thank you so much. It was very, very helpful. And thank you, everyone, for your questions and for joining us this afternoon. Cottage Primary Care Santa Barbara is located at 2329 Oak Park Lane in Santa Barbara. Immediately following this presentation, you will receive a link to request more information or to make an appointment with our Primary Care Santa Barbara clinic or a doctor at one of our other primary care clinics. We will also email a recording of this presentation in the coming days. If you have further questions or would like more information, you can always call 805-563-7010 or visit cottagehealth.org/primary care. A brief survey will appear after this webinar closes, and we'd love to hear your thoughts. Thank you again for joining us, and have a happy and healthy rest of your day.